During the webinar, you'll receive an email with a link to the evaluation. This webinar is approved for 1 point. I would like to introduce Ned Presnell. Ned is a LCSW and the Executive Director of Clayton Behavioral Treatment Programs in St. Louis, an adjunct professor and senior data analyst at Washington University in St. Louis, and a consultant for Missouri State's targeted response to the opioid crisis. He divides his time between clinical work, education, and research. Okay, Ned, if you're ready, I will hand things over to you.
Okay, welcome to this webinar. As she said, my name is Ned Presnell, and I'm coming from St. Louis. I'm presenting from St. Louis. St. Louis is one of the epicenters of the overdose epidemic, and certainly for Missouri, this is the region where we have a fentanyl crisis and just a lot of lost lives. I'm going to be presenting on the medication first principles of opioid use disorder treatment and talking a bit about how that's been implemented in Missouri. I want to just do a shout out to Rachel Winograd, who's the STR director, State Targeted Response to the Opioid Crisis, the grants that each state got, as well as the State Opioid Response Grant. She's works out of the University of Missouri in St. Louis and was one of the main developers of the medication first model. Rick Ruscio is my primary research collaborator. Louis Jufra is my primary clinical collaborator, and the Missouri Department of Mental Health has really stepped forward to try to change treatment in Missouri so that more people have access to life-saving medical treatment. If you look at this chart, you can look at our last major acute epidemic of mortality, the AIDS epidemic, in which we had an illness that was spreading throughout the population, and we were having escalating mortality associated with it. If you look at the black dots, those are AIDS diagnosis and AIDS deaths. This dotted line right here is the number of deaths. And then you see this very sharp decrease in deaths in about 1995. At the same time, you see these blue dots, which are people living with HIV and AIDS but not dying. This is what a well-controlled epidemic looks like. We never want to have an epidemic of mortality that we have to get in front of and try to change, but this is what one looks like when it is affected in that way. You can see here in 1995, there was the introduction of highly active antiretroviral therapy. Those effective medications, which we didn't have in the past, were diffused throughout the treatment system, and people's lives were saved, even as the incidence of infection continued to rise. This is a look at the opioid epidemic, which now claims more lives than the worst year of the AIDS epidemic. More than 500,000 people have died from this epidemic. It's on the scale of the Civil War. More deaths per year now than car accidents when we didn't have seatbelts, the worst year of car accident deaths, and the worst year of gun violence deaths in the United States. So this is really the acute mortality epidemic of our lifetimes and really the past few generations. The problem is so great that the Global Commission on Drug Policy in 2017 got together and did a well-studied document looking at the opioid crisis in North America, asking the question, you know, why isn't this epidemic under control? Why aren't we able to get it under control? One of the #1 findings they had was that in the United States, there is a huge prejudice against substitution therapy with buprenorphine and methadone. And because of that, only 8 to 10% of treatment programs offer substitution therapy. Now, since 2015, I follow the data, and that has been growing, but it's still more likely than not that someone will show up at a treatment center and not receive pharmacotherapy for opioid use disorder. Now, I want you to take a step back, and I'm going to do a little thought experiment with you. Probably all of you have heard the analogy of opioid use disorder or opioid addiction with something like diabetes. And really, if you think about it in terms of type 2 diabetes, it does share a lot of the same traits. It's heritable. There's a genetic vulnerability activated by environmental exposure, which causes the illness. It's progressive over time. Generally, people manage it with medication and lifestyle change together. Both have an influence on the illness. And full or partial remission is often followed by flare-ups. We call them relapses or overdoses in opioid use disorder, but really they're flare-ups of the symptoms associated with opioid use disorder, and oftentimes people need multiple episodes of treatment to manage the illness. Sustained uncomplicated remission is the exception, not the rule. If we look at the treatment episodes data set, 1 out of every 4 persons that come to treatment with opioid use disorder or heroin addiction in particular have already been to treatment 5 or more times. So it's managed through many treatment episodes. There was a study that came out that looked at just how much leverage can we get from the lifestyle changes in persons with type 2 diabetes. They really wanted to see, most of the time, type 2 diabetes is managed with medication, but lifestyle changes also help, and they really wanted to see if some intensive lifestyle change would improve outcomes significantly. They looked over 4 years, and in the first year, they randomized folks to just normal treatment without any lifestyle change intervention, and to a treatment condition where they basically had what was like an intensive outpatient program for addiction, but for type 2 diabetes. They saw the dietitian, they had support groups, they had counseling, and all of that counseling was focused on making lifestyle changes that would put type 2 diabetes into remission: control weight, control diet, exercise, etc. At the end of the first year, 3 out of 100 people who got treatment as usual, that was just a visit with the doctor, a little bit of health coaching, and you're on your way. 3 out of 100 people with that normal treatment as usual were able to come off their medication after a year. 11 people were able to come off of their medication at the end of the year if they were in the intensive lifestyle change intervention. So there was a significant effect associated with this lifestyle change intervention. If you took those 11 people and you put them in a room together and you asked the question, can people get off their medication for type 2 diabetes through lifestyle change? Probably they would look around at each other and say, yeah, you can do it. I did it. You did it, right? It works if you work it. This type of inference in science is called selection bias. You take a group of people who are ever able to make a change, and then you ask them if the change is possible. And although mutual support programs like AA and NA, 12-step groups, have no obligation to be scientists, the inference that we've drawn in the treatment field since the dawning of these 12-step groups is we look at the people who are successful, and then we look at the people who are still affected by the illness, and we say, look, they have the solution. It works if you work it. But managing a public health crisis like the opioid use epidemic with that kind of approach it does not work. Consider this. If you took those 11 people and you inferred from their success at coming off of medication, now incidentally, if you follow the study on over the 4 years, nearly all of those got back on their medication to manage the illness over time. But if you take them at the end of those years and you say, hey, because these 11 people were able to manage their diabetes without medication, the other 93 should do, or the other 89 should do the same thing. Those other 89 should get off their medication. What would you have in that case? You would have an epidemic of diabetes-related morbidity and mortality. People would just start dying from unmanaged type 2 diabetes. What I maintain is that one of the reasons we can't manage our opioid crisis and start reversing the trend in opioid-related mortality is because in too many cases, not in every case, not in every setting, not with every practitioner, but in too many cases, we're still using this false inference. People will show up in order to get on medication, which I'll show you the evidence for the effectiveness of medication in a moment, but they'll show up to get on medication, and the first question that will be asked is not how effective is the medication and how effective is it over time, what are the side effects. The first question is often, well, how long do I have to be on the medication? The patient might ask that, the provider might ask that, the counselor might ask that, oftentimes the family asks it, or there's just a policy in a treatment center that, well, we only give medication for 7 to 10 days, or we only give medication for 14 days, or there's a strong encouragement to come off of medication. But with that encouragement, more and more people have unmanaged opioid use disorder, and that contributes to our mortality epidemic, which I'll explain a bit more. So unlike the selection bias of saying, okay, you know, some people are able to get off medication and manage their opioid use disorder, the science of recovery tells a different story. The science of recovery looks at the whole population of people affected by opioid use disorder and asks the question, how do people respond to different types of treatment? So Massachusetts has looked at their Medicaid data, and this is looking at people with any opioid use disorder diagnosis over 3 years of treatment, who received any treatment rather, for opioid use disorder diagnosis, and there are 3 treatment groups. There's methadone, which is red here, there's buprenorphine, which is blue, and then there's psychosocial treatment, that's non-OAT treatment, non-opioid agonist behavioral health treatment, which is the green. So that's what we consider, you know, psychosocial treatment. In the first month, the relapse rate in the psychosocial only group is 9 times higher than the medication groups. Now imagine people coming to treatment that first month, the crucial month in which people are stabilized in treatment, and having a rate that's 9 times higher in one treatment modality. And then over time, that relapse rate remains extremely high in the psychosocial only group compared to the medication groups, which remain stable. But this chart dramatically underestimates the relative effectiveness of buprenorphine and methadone, because if treatment is this ineffective, if there's so much relapse associated with a treatment condition, patients just drop out. And so at 12 months, the retention in methadone treatment is 52% in this group, in this study, 33% buprenorphine. But at the end of 12 months, only 1/3 of the observation period in the study, only 12 out of 100 people are still left in the psychosocial treatment group. Again, if you look at this randomized clinical trial where people are randomized to buprenorphine or methadone, and you look at how people are doing over time, again, I often show this chart to people when they ask me the question, well, how long should people stay on buprenorphine? How long should people stay on methadone? And the answer I always give is, this is all we know scientifically. All we know is that any point in any observation period that in any study that I've ever seen, people that are on medication are doing better than people who are off medication. So we don't have any study that says, hey, this is an optimal time to taper off your buprenorphine or to taper off your methadone. We have anecdotal evidence of people who do that successfully, but anytime we study the treatment population or a treatment sample, the folks that stay on medication do better than those who come off. In this particular study, over 60 months, 5 years, at any point in the study, the past month illicit opioid use, which is what you're measuring here, is 3 times higher in the people that are off medication than the people that are on medication. What this difference translates to in terms of mortality is that if we look at treatment cohorts over time as well, and we can look over, this is a meta-analysis of all treatment cohorts for the people who receive methadone with 1 to 13-year observation periods. At any point, or on average rather, in these cohorts, there's the mortality rate for people that are in treatment, that are on their medication, is 70% lower than people that are out of treatment. And in buprenorphine treatment, there's a 50% reduction in mortality risk when people are in treatment versus out of treatment with an observation period of 1 to 5 years. Now, I have a friend who went to the doctor, and he was borderline hypertension. And the doctor said, you know, we're getting more aggressive with treating hypertension these days, so I'm going to put you on a hypertension medication. And my friend didn't want to be on a medication. Who does? Who wants to be on a medication for chronic illness? However, we all will be by the time we die. Pretty much everyone will be on some medication by the time we die if we live to an old age. So he said, well, I'll take the medication, but is that really my only solution? Could I engage in lifestyle change, for instance, and bring my blood pressure down? And the physician said, well, maybe. You can give it a try, make these changes, come back to me in 6 months, we'll take your blood pressure again, but start the medication. So he did. He took the medication, he made the lifestyle changes, and he was rigorous about it. He lost weight, he cut certain things out of his diet, he went back, and he recalled, he said, you know, I was really frustrated because I went in and the doc checked me out, kind of looked at me, took my blood pressure, and wrote me another script. He didn't even mention the possibility that maybe this was temporary, I didn't need to be on the medication. And so I brought it up. I said, you know, last time you said if I make these changes, then maybe I can come off the medication. And the physician said, oh, okay. Now with hypertension and cholesterol, physicians often have these little algorithms they can use in computers. So he went into the computer, he typed in height, weight, age, you know, blood pressure, if he's on medication, and he said, well, according to this algorithm, your risk for a heart event is 40% lower if you stay on the medication. And so my friend said, well, 40% lower. I mean, that's a significant reduction in risk. Okay. No problem. A risk for a heart event is not actually a risk for death. It's a risk for something that could lead to death. It's certainly a serious event. But the reduction in risk when people are on medication versus off medication is actually a risk for death. It's for mortality. And so it's mind-boggling to think that any practitioner around the country in any setting would say, I think it's best that you get off this medication. In no other field of medicine would we recommend coming off a medication that lowers mortality risk by 50 to 70%. And yet historically, it's getting better, but historically in the substance use disorder treatment system, it has been commonplace. At the beginning of this webinar, I asked the question, how many people think you can treat opioid use disorder effectively without pharmacotherapy? And more than half of people said they thought you could. And while that is not an ill-intentioned opinion, it's not supported by science. There's no evidence. At the beginning of a class I teach on addiction, I've taught 10 times now at Washington University Social Work School, I start every class by saying to students, if you can find me one well-controlled trial in which you can show that patients' mortality risk decreased when they had opioid use disorder through a psychosocial intervention alone, you don't have to do any other work for the class. We simply have no science to support psychosocial treatment reducing mortality risk in people with opioid use disorder. And why is that so important? Because we have the worst mortality epidemic of our lifetimes and of past generations associated with opioid use disorder, and we still are not always providing people life-saving medication. In places where they have taken the approach, we're going to get as many people medication as possible, they've seen a significant impact on overdose rates. France released buprenorphine, which is another name, is the generic name for Suboxone, in 1996, long before we released it at the end of 2002, the beginning of 2003. They released it without any special requirements. There was no waiver. There was no special training for the physicians. It's a very safe medication. And they released it without any naloxone in it. So it was just pure buprenorphine. Any doctor could prescribe it. Insurance generally covered it. I mean, France has almost universal health coverage, so their insurance people had coverage for it. And so if people wanted it and they had opioid use disorder, pretty much they could go into a doctor and get it. 20% of prescribers started prescribing it in France versus only about 2% of prescribers, 2 to 4 now, I guess, in the United States. And you can see here that these are the number of people that got on buprenorphine treatment, and this is the number of overdose death rates. You can see this directly inverse proportionate. This is the number of people that got onto methadone in that period. So even on a geographic scale, we can see that diffusion of effective treatment, just like in the AIDS epidemic, diffusion of effective treatment reduces mortality risk. In Baltimore, when buprenorphine first came out, they made a similar push to get people access to buprenorphine. It was called the Baltimore Buprenorphine Initiative. And during those next years, as people received treatment with buprenorphine, Baltimore saw a dip in its overdose death rate. Access has not been universal in Baltimore, and that death rate has gone back up since that time, partly as a result of the Baltimore Buprenorphine Initiative was not sufficient, partly because of the fentanyl crisis that has made the heroin supply so much more lethal for everyone. But you can see that their initial impulse to get people medical treatment paid off. Now, I'm a social worker. I spend 3 days, 2.5, 3 days a week in a clinic. I do individual therapy, couples therapy, family therapy. I work with families, a lot of whom have addiction, sometimes just mental health problems, other mental health problems. And so I believe in providing psychosocial treatment. But I also have to ask the question, what does the treatment I offer add to pharmacotherapy for opioid use disorder? The Cochrane Review, which always is a site or a group that simply does meta-analyses of treatment to come to the conclusion of what's effective and what's not effective and how effective it is for what outcomes. In their most recent meta-analysis of what psychosocial treatment adds to buprenorphine and methadone treatment, to pharmacotherapy, they found that for the considered outcomes of retention and illicit opioid use, in every randomized clinical trial they could find of contingency management, cognitive behavioral therapy, motivational interviewing, just intensive modalities that were added in a very strategic way to pharmacotherapy, there was no improvement in patient retention and no improvement in the amount of illicit opioid use in those studies. Now, a couple things about that. The clinical trials are generally short. We don't generally have long-term clinical trials because they're too expensive. So how much benefit people get from psychosocial treatment when it's intensively given at the beginning of stabilization with an addiction is one question. But if you think of addiction as a chronic illness, and you think about the lifestyle changes and personal changes and co-occurring disorders that people address over the longer term, over the first and second and third and fourth year of counseling or therapy, while they're managing more successfully or less successfully their addiction, these studies don't capture that. These studies don't capture those longer term changes. And I think that psychosocial treatment has a role to play in that. I certainly think people should have access to psychosocial treatment. But what I, as a psychosocial provider, also conclude is that it's never my job to get in the way of someone and their physician or someone in their medical treatment. It's never my job to counsel someone out of staying on their medication or counsel them into receiving a type of medication or type of treatment in which there's no access to medication. And yet we know that this happens a lot because in one study, we know it all, and all of us know that this anecdotally, I'm sure, but there is one study that asked the question, why do people discontinue buprenorphine maintenance treatment? That's what BMT is here. This study found that in the majority of patients who they looked at across different studies, most patients stopped receiving buprenorphine treatment involuntarily, whether because there were program requirements that they taper off or they couldn't make all the psychosocial treatment that they were prescribed. And after they were discontinued, there was a 50% relapse rate just in the first month after coming off of medication. So it was the expected outcome. Now go back to the type 2 diabetes for a second. Imagine if at the end of, if a patient came to an endocrinologist who treats type 2 diabetes, and the endocrinologist said, okay, listen, I'm going to give you a medication that will help you control your blood sugar. But you have some lifestyle factors that are contributing to this illness, and you're not going to get as well, you're not going to manage your type 2 diabetes as effectively unless you start exercising a little bit, maybe just try to move a little bit, walk 15 minutes 3 times a day. And you need to cut these 3 types of food out of your diet. Stop eating hydrogenated fats and et cetera. And just make a few changes. And you know what? Take this conversation and take it to the dietitian, and over time work with the dietitian on making some longer term changes to your diet. At the end of a month, say this patient comes back and says to the doctor, "Doctor, I took my medication every day as prescribed, and some of the symptoms, man, I checked my blood sugar pretty regularly and it was a lot more stable. But I didn't do any of those other things you suggested I do. I didn't change my diet, I didn't exercise, increase my activity level, and I skipped my visit with the dietitian. How many endocrinologists would say, well, you didn't meet my program requirements, no medication this month? None. Every endocrinologist would say, oh my gosh, great, I have a patient who's medication compliant. We'll work on these other things over time, because we have time. This is an illness that's going to be managed over months and years. We don't have to make all our gains in the first month. And yet, so often in treatment programs, buprenorphine is made contingent upon engagement in psychosocial services. That is a barrier not only to continued treatment, but it's often a barrier to treatment entry as well. And I'll give you an example of that later on in the presentation, where a person looks at all the things they have to do in order to get medical treatment in a program, and they say, well, I just can't do all those things. I have kids I have to take care of, or I have a job I have to get to, and so I guess I just can't access the treatment that's available in my community. There's also a misconception at times that somehow Suboxone or buprenorphine or methadone is incompatible with 12-step programming. At the very beginning of this presentation, I did this analogy about 12-step programming. It works if you work it. It really does work if you work it for people that engage in that way. And I refer people to 12-step programs on a daily basis. And I help them overcome their resistance to them on a daily basis. Sometimes that takes months, sometimes that takes years. Sometimes people jump in full bore, and sometimes people never do it. But what is often the case is that people that are on buprenorphine and their cravings are managed and they feel better, that they are able to engage in 12-step programming very productively. So in this one study, patients were put on Suboxone and they were followed over 18 months. And at the end of 18 months, they were allowed to stop their Suboxone or stay on their Suboxone. There was it was an open label study. And at the end of 18 months, 76% of patients chose to stay on their Suboxone, but those who chose to come off of it were less likely to have a home group, less likely to have a sponsor, less likely to be attending meetings, and they were more likely, the patients that stopped their Suboxone voluntarily, to be engaging in all the behaviors that we associate with addiction. People that stayed on medication were doing much better in their mutual support program. Well, that makes a lot of sense, because if my primary symptom of craving, which drives all the behaviors of addiction, is well managed, and my prefrontal cortex, which allows me to make reason and judgments and be goal-oriented, is freed up, then doing something like engaging in a life transformative program like the 12-step programs is something I'm more able to do. Whereas if my cravings are unmanageable, it's very difficult to engage in any prefrontal cortex executive system activity. So because of everything that I've said so far, when we were thinking about how to address the opioid crisis in Missouri, and in particular how we would do that in traditionally psychosocial treatment programs, we came up with what's called a medication-first model. We're kind of getting rid of this idea of model because it's not a model that is like the nurse care manager model, which tells you how staffing patterns need to be, et cetera, but it has some really core principles that can be applied pretty much across the treatment system. It's based on, the language is based on the housing first approach. Before housing first kind of caught fire as a way to address homelessness, there were housing programs in which there are a lot of obstacles for people to both achieve and to retain housing. And so, in order to get housing, you first had to be in treatment, or you had to demonstrate sobriety, or you had to demonstrate that you'd completed some job training, or whatever the case may be, that you're attending your psychiatric visits. But what happened in that scenario was that people who had housing insecurity, being homeless is not just about not having shelter over your house that night. It's about the deep sense of insecurity that causes. And if you have shelter for some time, if that shelter is insecure, the anxiety associated with housing insecurity is still high. So if a patient or a person got housing through a housing program that wasn't housing first, but they knew that they can lose it at any moment. If they relapse to substance use, if they stop going to treatment, if they lost their job or they didn't complete job training, whatever the case may be, they live with a permanence as a sense of housing insecurity. And so people in the housing intervention world said, hey, let's hold on for a second. How about we treat homelessness with housing, with secure housing? That's it. We'll just give people that are homeless secure housing. And then we will, just got a question, which I'll answer in a second. Then we will offer them voluntary services to address their substance use disorders, to address their mental health problems, to address their employment status, to address their co-occurring mental health issues. And in a voluntary basis, we'll engage them in those other services, but with housing secure. Because in that situation, a person's limbic system, that survival center of the brain, can calm down a little bit. At least they know where they're going to rest at the end of the day. And then they will free up that executive system so that they can start to be more goal setting, so they can be more collaborative in meeting goals, knowing that the rug's not going to be pulled out from under them. The medication-first approach is similar. I've actually had patients, or I've encountered people, not at the treatment center I work, that are on medication, and they're terrified of losing it. They're terrified of losing it because of arbitrary tapering requirements that a program might have, or because they're not making their groups, or they might miss counseling and then be taken off their medication. And they also live with this insecurity about their medication status. Medication first approach is designed to take away that insecurity of losing medical care. Now, a question that just came up, I hope I didn't miss any other questions. There might have been others that came up. Let me open my chat box here. The question that came up is, how much does it cost for people to stay on medication? And now the actual cost, and there's one other question I will answer. The actual cost varies a little bit, and I'm not sure if you're asking how much does a patient, okay, how much does a client have to pay per month? Well, that varies a lot. In Missouri, with the medication first approach that use state target response funds for the uninsured, the cost is free for people that can get a slot in those programs. If they have Medicaid, if patients have Medicaid in Missouri, if they're able to get into a program that uses medication, the medication's covered by Medicaid. I'm going to talk a lot more about funding later on, funding issues later on in this presentation. But if a person is paying out of pocket for medication, as a rough guide, I would say it's $12 to $15 a day for medication, both methadone and buprenorphine. You have to kind of shop around, get on the generic and such, but if you do that, I've seen people get medication as low as $6 per 8 milligram tablet, but it can range and go a lot up from there. Methadone at methadone clinics can be around $12 to $15 a day. Which treatment do you find more effective, Suboxone or methadone? Well, that's an empirical question, and the research suggests that methadone is a bit better for retention over time, but it's really hard to access because it's generally available in urban settings. There's sometimes only a few methadone clinics scattered around a state, whereas a doctor anywhere in rural areas or in places where there's no methadone clinic can provide buprenorphine, and people can get access quickly. So while retention is a bit higher in methadone, buprenorphine is more accessible, and that's why they both play a really important role. Buprenorphine also has some safety, a safety profile that's better than methadone's. If I take my whole bottle of buprenorphine, there's a very, very infinitesimal risk that I'll cause respiratory depression because there's a ceiling effect for respiratory depression. If I add a lot of other drugs with it, of course, I can cause respiratory depression, but by itself, it has that ceiling effect, and that's why the FDA, it's a Schedule III medication. The FDA considers buprenorphine safer than Adderall or Ritalin that we give to 10-year-olds for ADHD. It just is, it doesn't have a lot of risk in terms of mortality or harm that can come to someone. So for that reason also, buprenorphine can be kind of a frontline treatment because of accessibility and because of the safety profile. Now, methadone is safe because it's highly regulated, but by itself, it is synergistic with, not synergistic, it has an additive effect with other opioids. So if I go get my methadone dose and I pile some other opioids on top of it, there will be a additive effect and I can cause respiratory depression. That doesn't happen very much because once people are on a stable dose of methadone, the reinforcement that comes from using street drugs is really low, I mean, at least opioids. And so there's a low overdose risk in methadone treatment, but the drug has to be highly regulated because when it's prescribed for pain, we've seen a really steep increase in overdose associated with methadone that's not provided in the methadone clinics, but provided in pain clinics, because by itself it can be a risky medication. Where can we get more information about the medication first approach? Is it with credit to Missouri? Is it trademarked? Well, I developed a medicationfirst.org website where there's some medication. If you Google Medication First right now, Missouri's fact sheet about Medication First, Missouri STR, comes up first. In terms of development, none of us have chosen to try to copyright it. We want people to use it as widely as possible. And the developers were myself and Rachel Winograd at UMSL and the Department of Mental Health in Missouri. We all collaborated on developing this language and model and principle. And everybody can use it. It's not copyrighted. So we also like to stress that while this is a particular articulation of some principles that we think are well supported by science and which are targeted at one simple thing, saving people's lives and stabilizing them in recovery, the World Health Organization in 2009 largely articulated the medication first principles in their guidelines on what they call psychosocially assisted pharmacotherapy for opioid use disorder. It's kind of a mouthful. They say that treatment services, by which they mean agencies, should not deny effective medication if patients are unable to provide psychosocial assistance, meaning that if that's all you can do, if you're a primary care doctor, you don't have a counselor with you, but you get buprenorphine waived and you're willing to manage the opioid use disorder in some patients, the World Health Organization says from a public health standpoint, please do it. You can refer patients for other supportive services, housing, counseling, psychiatry to other providers in the community, but the first thing we need to do is stabilize them on buprenorphine or methadone. So this is a medication first principle that the World Health Organization articulated a long time ago, 10 years ago now. And while patients should be offered psychosocial support, the guidelines say, they should not be denied agonist maintenance treatment should they refuse such support. So under no circumstances should a person be robbed of their medical care because they refuse to engage in other services. For Missouri Department of Mental Health, we created 4 principles to guide the implementation of medication first in the specialty substance use disorder treatment programs in Missouri, the ones that received STR funds. And really the model was incentivized financially. Agencies get block grants that were not medication first agencies. Of course, they got block grant funds every year, which I'm going to talk a bit about. But if people wanted access to the state targeted response or the state opioid response dollars for treatment, they had to demonstrate through a readiness survey that they had buprenorphine capacity and that they were willing to implement a medication first approach to get people treatment. And the 4 principles that had to be implemented were that people should receive medical stabilization prior to undergoing lengthy assessment process. There's a psychosocial interventions. The first visit would be with the doctor. The Department of Mental Health actually changed the way that their billing system works. They had to have a programmer go in there and recode it so that the visit could be The medical visit could be first because before it was required that someone go through a lengthy psychosocial assessment even prior to stabilization medically. Individualized psychosocial treatment should be offered to patients. Now, these are comprehensive substance use treatment programs that are implementing MedFirst in Missouri, and the Department of Mental Health wanted them to continue offering the full menu of services, but they could not make those services a requirement to access medical treatment at any point. Medical treatment should never be withdrawn unless it's clearly worsening a patient's condition, and the medical management of opioid use disorder should be ongoing, not subject to arbitrary time limits or tapering requirements. And so agencies, this was a big change for agencies that were traditionally psychosocial treatment programs. And I'm going to talk a bit about that historic issue in a second. Sometimes people ask the question, well, I don't want to just give medication. It seems riskier, it seems unethical, or it seems something seems to be missing when you provide someone just medical treatment and not psychosocial treatment. I'll be the first one to say that when you provide medical treatment to someone with opioid use disorder, oftentimes they have many other needs that need to be met. And it is inhumane not to help them meet those needs, whether that be a need for housing or counseling or therapy for trauma or psychiatry for unmet mental health needs. But there's no incompatibility in wanting to provide and offer all those services to patients and to offer them and to do good case management and to provide those services in-house if you can, and saying, but I'm also going to give you medical security around your buprenorphine or methadone treatment. We're going to make sure you have access to that regardless of what else you do. So we're not advocating a medication-only treatment approach, but if a person has access to medication security and they choose only to receive medication, we're letting that be their self-determined prerogative. And while they're on medication, they're continually referred to other treatment, invited to other treatment on a voluntary basis, not a compelled basis. This is a very small study, but I think it's instructive when you look at the way the treatment system has been. I don't know where everybody is representing today, but in Missouri, it's often been the case that you call a treatment center, a comprehensive treatment center, and say, hey, I need a bed, or hey, I need a slot. And they say, well, keep calling every day. The wait list is now about 3 weeks. So a patient who's in the grips of addiction, who might not make that call very frequently, meets this barrier. So in this study, they said, well, when people are waitlisted for comprehensive treatment, let's just give them buprenorphine. Short buprenorphine visits with a practitioner and see how they do while they're waiting for an entry into treatment. At day 84 of being on a wait list, this is obviously a place where they had a long wait list. At day 84 of being on the wait list, people that received buprenorphine, most of them had stabilized and stopped using illicit opioid because on average, their days of opioid use have gone from almost every day, or about 25 days, down to about 5 days. But obviously in the group that received no treatment that was just on the wait list, they continued to use almost daily. So medication by itself does have a significant impact on opioid use disorder. And that doesn't mean that a person won't benefit once they're stabilized or once they get entry into a psychosocial treatment program for all the other things that are impacted by addiction. Another question. Question from the audience, which MAT is most appropriate for pregnant women? For a long time, the gold standard was methadone treatment. And the most recent research suggests that neonatal abstinence syndrome is lessened when women are put on buprenorphine compared to methadone. That said, they're both great options because it's recommended by every medical body that a woman with opioid use who's pregnant with opioid use disorder get on buprenorphine or methadone because they both stabilize the individual. They both put much less risk to the fetus than continued drug use. When a baby is born, they will have in almost all cases, neonatal abstinence syndrome. That is not addiction. An infant can't be addicted. They are physically dependent, and that dependency, they have no knowledge of anything. They've never engaged in drug-seeking behavior. They need to be weaned off of the opioids because they're dependent on them, and that's done with Suboxone, buprenorphine in some cases more recently. Traditionally, it's done with morphine. And then the baby's healthy, and the baby has it's a little bit like being born and having a sick, like a cold or a flu when they were first born. That passes, the baby's healthy and fine and develops normally. So both are good options depending on, really, I think in my own clinical practice, it depends on the severity of the opioid use disorder. If I think a patient is going to stabilize on buprenorphine, then I'll encourage buprenorphine treatment. If their addiction or the stability in their lives, or all factors suggest that maybe methadone is accessible to them and would stabilize them better. Because the thing is that the highest dose of buprenorphine is not as does not have as much agonism, is not as strong, I guess you could say, as the highest therapeutic dose of methadone. So some patients won't stabilize on buprenorphine that will stabilize on methadone. How do you handle patients who are diverting their medication and selling it? Let's see, I think I missed one though. Are there issues with prescribing naloxone for those clients who are currently using other drugs, benzos, alcohol, other drugs? Which MAT is, okay. I think you might have meant buprenorphine. But if you meant naloxone, it's a more confusing question for me, although it's important. So let me start with buprenorphine. Is there an issue prescribing buprenorphine with clients who are currently using other drugs, benzos, alcohol, other drugs? There's always issues with polysubstance use. The patient is less stable, they're more difficult to manage, but generally it's recommended that patients be prescribed buprenorphine even if they're continuing to engage in polysubstance use. This is so important. The one drug that doctors or nurse practitioners, providers are particularly wary about is benzodiazepines and alcohol, but benzodiazepines even more. And so a lot of doctors wouldn't prescribe people buprenorphine if they're taking benzodiazepines illicitly or prescribed, and they wouldn't, or they would say, hey, if you don't stop misusing the benzodiazepines, I'm going to have to take you off your buprenorphine. The FDA wrote a memo and said, hey, hold on. Sure. I mean, being a doctor means managing risk. A lot of the time, especially with an acute illness like opioid use disorder. The patient is at much greater risk if you deny them buprenorphine treatment or methadone treatment, or take away their buprenorphine or methadone if they're misusing other substances. So if you can stabilize their opioid use disorder or even decrease their opioid use by using buprenorphine or methadone and they're continuing to engage in other substance use, then they still should be receiving medical treatment, and you continue to work with them on other ways to stabilize. Sometimes that will mean going to a brief stay in residential treatment to stabilize. Sometimes it will mean just continuing to work with the individual and decrease risk. There's a huge spectrum of positive outcomes with people with chronic illnesses. There's full remission and then, all kinds of partial remission. A person who continues to use substances but who's reduced or eliminated their illicit opioid use is a person we consider but they may be in full remission for their opioid use disorder, but still in partial remission with respect to other substance uses, or not remission at all. With respect to naloxone, the only thing I'll say really briefly is naloxone, sending patients home with naloxone who have an opioid use disorder or are on significant opioids for pain should be considered the standard of care. The more take-home medication we give naloxone, more available to family members and patients, the more overdoses will be reversed, giving us more time to treat individuals with those conditions. Now I want to look at a couple historical and structural considerations for implementing a medication-first model. Adults with opioid use disorder have different, about 1 out of every 5 is uninsured, and about 3 out of every 10 receive Medicaid. About 2/3 of all treatment, especially in specialty treatment centers for addiction, are publicly funded. So really the publicly funded system has to bear a lot of weight in treating opioid use disorder and all addiction. In 2002, our treatment system was pretty bifurcated or compartmentalized. There was outpatient methadone treatment, and this is from a study of our treatment system that was published in 2002, and I use that year because it's right when buprenorphine was approved. So there was outpatient methadone at that time. There was long-term residential treatment, and there was outpatient drug-free treatment. That was what it was called in the studies. When this federally funded DATO study was done, looking at treatment outcomes and all kinds of treatment across the country, these were the 4 kinds of treatment they found. And both long-term residential and outpatient drug-free, as well as to some extent short-term inpatient, were all had no medications. In fact, short-term inpatient also had no medications for opioid use disorder. Maybe oral naltrexone. But so there was the methadone treatment, and there was all this drug-free. They call it drug-free treatment. I'm going to now change that term when I keep going. I'll call it psychosocial treatment. Drug-free just sounds strange to me, but that's what it was called back then. So when buprenorphine was released, we already had medical treatment for opioid use disorder, and we had psychosocial treatment for opioid use disorder. A lot of you might consider, when you think about these other long-term residential and outpatient drug-free, think that you had these psychosocial step-down programs that followed the ASAM criteria, for instance. Well, when we had this huge increase in opioid use disorder, starting in 2000 really, and just escalating, this big bubble here in the orange, this is the relative increase in the number of psychosocial only visits in our country, or episodes in our country. So while opioid use, this is the number of treatment episodes for primary opioid use disorder in the United States from 2002 to 2016, and the orange is psychosocial only treatment, and the blue is people that receive at least some medical treatment, although some of those might be just detoxification. This is outpatient. Okay, so this bubble shows that our increase in capacity to provide medical treatment for opioid use disorder did not keep up with the need for it, so that there was this burgeoning of more of psychosocial treatment episodes because we didn't have an increased capacity. Now, in the past few years, there's been a greater increase in especially buprenorphine treatment, in some places methadone treatment, but still the majority of opioid use disorder treatment episodes, and this is just outpatient, this doesn't even count all the people that just received detoxification, you're still more likely in the publicly funded treatment system to receive no medication for opioid use disorder as of 2016. And that's striking, right? But there's another thing we have to consider about the uninsured and the Medicaid population, which is during that whole period from 2002 to 2016, the uninsured were much more likely not to receive medication than people with Medicaid. Somehow and I think it's different in every state. I kind of know what happened in Missouri, but by and large, medications cost money. If I have my block grant funds, I just might feel less likely to want to spend that money on medications in a block grant funded treatment center. Whereas if a patient has Medicaid, that doesn't come out of my allocation. It's complicated, right? But the more that I was doing trainings on medication-assisted treatment years before we had, STR and SOR, and at that time I really focused on attitudinal change and education and looking at effectiveness. The longer I've done this, the more I realize how important money is. And in this case, there was just less money for medical treatment for people that are uninsured than for Medicaid. Now, in 2018, the block grant, to give you an idea of where the money for this publicly funded treatment system comes from, the block grant was $1.8 billion in 2018. We were having the state target response to the opioid crisis. We're getting another $500 million spread out through the states in 2018, and $1 billion spread out through the states for the new grant, state opioid response. So if you kind of put this all together, in the federal government, which was providing a large amount of money for substance use and opioid use disorder treatment, they were spending $1.9 billion in block grant funding for substance use disorders and $1.5 billion in OUD-specific grants to address the opioid crisis. At the same time, Medicaid was spending about $10 billion on substance use disorder treatment. But here's the difference. Grants are given to states, and then states generally contract with a system of contractors to provide opioid use disorder treatment. That system of contractors is that system that the Dato study studied, which is methadone clinics and the step-down residential and drug-free psychosocial treatment. So these grants are largely funneled through this system of contractors, which has historically been bifurcated between methadone and drug-free treatment. Medicaid dollars, however, if I'm a Medicaid beneficiary and I'm a Medicaid recipient, anybody that takes Medicaid and agrees to treat opioid use disorder, I can get treatment from. And so now federally qualified health centers are treating opioid use disorder, rural health clinics, OTPs, hospitals, and drug-free treatment centers are all starting to integrate buprenorphine treatment. What that means is that Medicaid beneficiaries have a lot more access points to medical treatment for opioid use disorder. And so that raises a question that I always want people to go home with and to consider: what is these block grants that go towards treatment of the uninsured in the country? What is my state doing to expand this system and get people access to medical treatment? Because historically, these drug-free treatment centers have had a really hard time implementing maintenance buprenorphine treatment. And yet some of the medical settings have an easier time because they have a chronic care ready model, they already have doctors available, et cetera. And what I'm afraid of, and I actually know is happening through some data I've looked at, that disparity that I showed you between the uninsured accessing medical treatment for opioid use disorder and Medicaid recipients accessing medical treatment, that this disparity is only growing because there are more places coming online that take Medicaid, but the system of contractors is a more fixed system and more difficult to manage. I can tell you in our state, what is my state doing to expand the system? They're providing a lot of resources to educate within the SQHCs and get people online providing buprenorphine, and also implementing the medication first model in the drug-free treatment centers. We are a non-Medicaid expansion state, which means we're losing out on a lot of money that could be being used to expand our network of opioid use disorder treatment. But we have not really found a good way yet to get more of these dollars for the uninsured into this system of care. We do have like a emergency department intervention where we send people in and refer them to the quote drug-free treatment centers, which really are psychosocial treatment programs now, which are required to implement buprenorphine treatment if they want to get the STR dollars. But it's a work in progress. And I just think we should all be asking this question in the midst of this crisis. If our numbers aren't going down, it might be a problem with treatment access, but if it's a problem with treatment access, it's a problem with money. And we need to think about where the money's going and coming from. So if we're only funneling money into the specialty settings, we are missing the mark in implementing system-wide medication-first treatment. We need to be thinking of the whole healthcare system, all the places where people present for treatment with opioid use disorder. They present in the emergency department. They present in psychiatric hospitals. They present in criminal justice settings. They present in hospital units. They present in primary care. All of these places are places where med-first principles can be implemented. I think I have a question here. We don't have any strong, what are the long-term effects of buprenorphine? No significant effects that I'm aware of. It's a pretty clean medication. How do you handle patients that are diverting their medication and selling it on the street? Frankly, it's the least dangerous opioid, and diversion is not nearly as big a problem as the prescription opioid epidemic. It's just not a major health concern from a public health standpoint. if a patient is taking buprenorphine on the street, generally they're trying not to use heroin that day. In St. Louis, if they can get buprenorphine and they take it that day instead of using the fentanyl-laced heroin or the pure fentanyl that's going to kill them, I much prefer that from a public health standpoint. Are they allowing folks who are in an OTP methadone clinic to just be on medication if they choose not to participate in counseling? The Department of Mental Health is trying to make sure that some of the methadone clinics had previously been doing mandatory tapers if people weren't going to counseling. They always offer counseling, but they are trying to move to a medication-first model in the OTPs as well, offering counseling but not taking people off medication just because they aren't attending. Is there a standard drug history that the client has to have, and how is that verified? What about drug-seeking clients? So I think that's a question about severity. If someone's seeking buprenorphine, then let them seek it. I mean, it's a substitution therapy. It's a much safer substitution for anything else they could possibly be using. In terms of drug history, I think the questioner is asking, you know, well, if someone comes in, how do you know they should receive medication? If they're opioid dependent. If they're opioid dependent, they should receive medication. Even in studies that don't take out all the heroin and fentanyl and just look at prescription opioids, people that are have prescription opioid use disorder, they have much better outcomes receiving buprenorphine than on maintenance buprenorphine than even if they taper off of buprenorphine. So there's always this idea, well, like, okay, well, maybe some people that are opioid dependent shouldn't be on maintenance care. Let's do a study of people that are prescription opioid dependent, because that's usually a lower severity than heroin or fentanyl. And so there's one study that randomized people to maintenance buprenorphine or a buprenorphine taper. And the people that were randomized to maintenance buprenorphine did far better over time than the people that were tapered off. When people are tapered off and they're opioid dependent, they generally, in high numbers, high proportion, go back to opioid use. How do you recruit doctors and medical facilities to participate in the program? That's a challenge. If a traditional substance use disorder program, a psychosocial treatment program wants to provide the medication-first model, they want to get the STR, SOR funds, they face the challenge of finding a community doctor to partnership with. I will say that the rates that the substance use disorder treatment programs get for those physician visits are adequate. They're higher than the standard Medicaid rates, and there's even an administrative fee on top of that helps them, you know, provide medical treatment. But they still have to find providers, and all I'll say about that is that it's been a challenge. It's also one of the reasons that I've been advocating from the very beginning not to focus just on the psychosocial treatment programs, but to focus on places that already have doctors, already do chronic disease management, because it's often much easier to get buprenorphine treatment started there than to try to get psychosocial treatment programs to do what they're not accustomed to do in a model of treatment that they're not accustomed to. It's great when they do it, but it just can't be the only solution. Is there a standard drug history? Is Missouri using the medication-first approach in its correctional systems? So far, we've only been able to get extended release naltrexone into the treatments into some prisons. I believe that one of the STR initiatives right now that's not quite implemented yet is getting buprenorphine into the St. Louis County Jail. So we're trying, but as I'm sure you know, that's difficult. But that will bring me actually to these next slides, and then I'll come back to questions. So when people present in the emergency department, they've often just been sent away without medical treatment. If people have a non-fatal overdose and they receive medication in the next 12 months, receive it at any point in the next 12 months, their reduced risk for 1 year mortality is 70%, buprenorphine or methadone. In this group here, the group that presents for a non-fatal overdose, where they get their overdose reversed, and then over the course of 12 months, 1 out of every 10 persons died if they didn't receive medication, and that risk was reduced by 70% in people that received buprenorphine or methadone in the next in the next year. That's a massive reduction in mortality risk by accessing treatment. And so that raises the question, why don't emergency department visits start people on medication and then transition them to medical treatment? And some have. Some have. And that's starting to happen all over the country, really. We have a program, like I said, it doesn't really support induction in the emergency room, although a little bit of that is happening, but it does support connection to treatment. Really what we need to be doing is inducing people in the emergency room and then getting them connected to treatment. In the criminal justice setting, so this is the answer to that question of just about effectiveness. In Rhode Island, they said they have a smaller incarcerated population. It's a small state. So they said, okay, we had 4,800 admissions for incarceration and 4,000 releases in the first 6 months of 2016. And a few of those people got medical treatment while they were in prison or incarcerated. That's also in jails. Let's give everybody that has an opioid use disorder access to these medications. So they drastically increased their buprenorphine and methadone in recently incarcerated individuals. And they found that they had a 60% reduction in that time period over the prior period, the prior comparable period, in the proportion of overdoses in their state among recently incarcerated individuals. Why would they have a statewide impact just by implementing medication first principles in the incarcerated population? For the same reason that there's a huge impact on treating people with non-fatal overdose. Because people with non-fatal overdose and people who are incarcerated with opioid use disorder have about a 10% mortality risk in the next 12 months. The mortality risk in the people with non-fatal overdose comes from the fact that they're obviously people that are at risk for overdose, and if they overdose again, it's kind of like suicide. The best predictor of a completed suicide is a past suicide attempt. Well, the best predictor for a fatal overdose is a non-fatal overdose. So if you treat those individuals, you're going to get even more bang for your buck in terms of reducing statewide mortality. And in the incarcerated population, it's because when patients are incarcerated, they lose tolerance. And so when they go back to using opioids, their mortality risk is even higher than in the standard population of people who use opioids. And for that reason, in Rhode Island, in medical science, there's this statistic called the number needed to treat to save a life. The number needed to treat to save a life in Rhode Island that was calculated after they did this intervention in the incarcerated population was 11. 11 incarcerated individuals needed to be treated to save one life. Very similar to how many people needed to be treated to save one life in the non-fatal overdose study. And that can have a statewide impact in intervening in these high-risk groups. So we looked at emergency department, we looked at criminal justice settings. Let's look in the hospital. There are a couple studies in the hospital units. I saw a few presentations when I was at the MRSA conference on people showing good results from med-surg hospital units. I didn't include a study to show you, but what I did, I can tell you anecdotally what the theory here is. In Barnes-Jewish Hospital, which is the largest hospital in the St. Louis region, there are 20 to 30 beds filled at any given time with people with IV drug-related infections. Historically, they've gone in with IV drug-related infections, primarily opioid use disorder, and they've received 5 to 6 weeks of IV antibiotics for endocarditis and joint infection, where they're in the hospital receiving these medications to get rid of these infections, and they receive no medical treatment for their opioid use disorder. Even though when a person's hospitalized, you don't even have to be buprenorphine waived. You can provide methadone or buprenorphine while a person's hospitalized, stabilize them medically for their opioid use disorder. Imagine, it's going back to the type 2 diabetes, it's like someone came in and needed a limb amputation for their type 2 diabetes because of type 2 diabetes that was way out of control. The hospital performed the amputation, but didn't regulate the person's blood sugar. It's completely outside the way that medical treatment is typically given, because we've never really integrated the treatment of addiction into the normal treatment system, the normal healthcare system. So this shouts support for hospital opioid use treatment. This is a started out of California, where they've implemented opioid use disorder treatment in hospital settings, and they've created a service now that is national and is a consultation service where they have toolkits and webinars and protocols. Basically, they've developed all the guidelines any hospital needs to implement effective opioid use disorder treatment in the hospital. And so it's a great resource if you're in a community where you want your hospital to start integrating treatment. And they have protocols, and I mean, it's very, very detailed, the kind of guidance they give. And so I encourage everybody to take a look at that. And then finally, the heart of the treatment system is primary care and specialty care. Primary care is where chronic diseases are managed. Specialty settings are where people are stabilized when primary care is not sufficient. So if I'm having a significant cardiac event, I go to a specialty setting for stabilization, I get my medications changed, and then I go back to primary care for maintenance. That's the heart of our treatment system in the United States for all chronic care. How does primary care, so when on the State Target Response Grant, my primary job has been going out to primary care settings and trying to get them to encourage them to implement buprenorphine treatment, provide trainings. I've trained several hundred people, practitioners at a different level on implementing medication first principles in primary care. I've also, as a data analyst and researcher, been looking at Medicaid data and looking at the different settings in which medication was given from 2008 to 2015. This is also where I realized that there's this whole treatment system that the uninsured have no access to. That if people are providing Medicaid-funded buprenorphine treatment, it's only reaching the Medicaid population. And in a state like ours, where there's a huge population of uninsured people with addiction because we don't have Medicaid expansion, that's a major issue. So in any event, there were 4 groups that we looked at. People that were getting buprenorphine treatment in a specialty treatment center, people that were getting what we call office-based opioid treatment, which could be a primary care center primarily, or it could also be a psychiatric office. There's a psychiatrist that takes Medicaid. An outpatient hospital setting, this is not a specialty addiction setting. It's like if you went for an exam, it's a hospital clinic basically on an outpatient basis, and then medication only. Now someone might look at this and say, medication only, how is that a setting? Well, it's a setting because these are Medicaid patients who we had pharmacy claims for, but they had no provider visit associated with the pharmacy claims. And you're like, well, how is that possible? If you think about it for a second, just ask yourself this question, and I think you'll understand why. How easy in your community, in your state, is it to find Medicaid covered physicians who will prescribe buprenorphine? If a patient comes to me and says, I want to use Medicaid and I want to get into a primary care facility that provides buprenorphine, I now know we've kind of had an expansion of it, but historically, it's been 2015, it was much more rare. And so these are patients who are finding a doctor and paying out of pocket, receiving a buprenorphine prescription and using their pharmacy benefits, but not having a covered provider visit. And you can see that retention in this group is low. Because if you're paying out of pocket, obviously that's a disincentive to staying on medical treatment. The office-based opioid treatment with buprenorphine has the longest retention and significantly longer than the specialty treatment centers when they use buprenorphine. Why is that? Well, I mean, we can hypothesize that part of the reason is that specialty treatment centers have historically used buprenorphine a lot more for detoxification, whereas in office-based settings, they more often provide maintenance, et cetera. It's important for primary care facilities to understand that they can do an effective job providing medical treatment for opioid use disorder, and they don't need to become a specialty treatment center. They need to have some increased competence in treating addiction, but their primary competencies of managing chronic illness, of providing pharmacotherapy, of being symptom-focused are sufficient for providing good opioid use disorder treatment. All of those medical settings provided very, very little psychosocial treatment, less than 0.1 hours on average, compared to the specialty centers that provided more psychosocial treatment, but had much lower retention. And when people were in these medical settings, the risk is lower if your number here is below 1. And so the risk for ED visits and hospitalizations in the outpatient hospital, office-based opioid therapy, and even the pharmacy only, the risk is lower than when you compare it to specialty settings that provide buprenorphine. And of course, compared to psychosocial only treatment, which is what this group is, the risk is much higher in that group for ending up in the emergency room to visit, not unlike the Massachusetts study I showed you at the beginning, where psychosocial treatment just doesn't stabilize people as effectively. This is just a sort of anecdotal. In one area of Missouri, Springfield, I looked at the TEDS data, because you can look at TEDS data, the treatment episodes data set, and look at how many people receive medication in specialty treatment episodes. And you can look by Census Bureau area, so CBSA. And so for the Springfield CBSA, in 2015, the orange is the number of OUD treatment episodes without medication, and the blue is with medication. What that shows you is that the main specialty treatment settings in this area had not adopted buprenorphine integration at that time. And they have still struggled in that area to adopt buprenorphine integration. But one federally qualified health center came online and started going gangbusters providing a medication-first model of treatment. They were actually the first FQHC that I went and did training at, and they've also gone out and got their own grant money to provide treatment to the uninsured. They've done an unbelievable job. Not only did they provide, not only are they now probably the largest opioid use disorder treatment provider in the area, and they're providing all medical treatment because that's what they do, but more people came to treatment. They had an increase in the number of people coming to treatment because when you lower the threshold and you don't create a lot of requirements of individuals, then more people will show up and say, I need help, because it seems achievable to see my physician, to start medication, to get stabilized, if I don't have to do, for instance, a partial hospitalization where I can't work, or I have to do an evening program where I have to take care of my kids, et cetera. So the advantages of chronic care ready medical settings like primary care, some community mental health centers I think are really chronic care ready medical settings because they always have medical practitioners. Patients always see a medical practitioner like a psychiatrist. It's symptom focused, and there's this idea that mental illness is managed long-term with pharmacotherapy, not short-term. And so if I'm managing schizophrenia or bipolar, nobody asks, when are you going to come off your medication? They say, please, please stay on your medication. And so chronic care, community mental health centers that I've worked with actually take that same approach to opioid use disorder and do a really excellent job managing it. When people are managed in primary care, they also attend to their physical health more effectively. So if someone is receiving buprenorphine maintenance treatment, it improves their compliance with nationally recommended preventative primary care screenings. My favorite, I won't say my favorite buprenorphine prescriber, but one of my favorite buprenorphine treatment providers in the St. Louis area is this woman, Kadika Turner. And she just treats opioid use disorder as part of the overall health care of her patients. She does prenatal care, she does postpartum care, she treats the hepatitis in people that have IV drug-related infection, she treats their diabetes, their hypertension. She's a family care physician, and one of the things she treats is opioid use disorder, and she stabilizes them on buprenorphine. That has two benefits. One, obviously, recovery is difficult, and having good medical care when you're in recovery, integrated medical care, is a real boost to someone's sense that, okay, hey, life can be better. But secondly, it destigmatizes addiction. I don't have to go to this other place to treat my opioid use disorder. My doctor treats it, like any other condition. And I just don't think, I think we cannot underestimate how much that dignifies the individual and destigmatizes the illness of opioid use disorder. There are a lot of great manuals out here now for low threshold models of care, medication as treatment model for opioid use disorder in primary care out of HRQ. My personal favorite, Boston Medical Center, the nurse care manager model, partly just because it's incredibly comprehensive. So it tells you, kind of like the SHOUT model or the SHOUT resource for hospitals, the Boston Medical Care Center has done the same thing for primary care in terms of treating not just opioid use disorder, but all addictions within the primary care setting. Let me run up here and see if I've missed any more questions. Neurologically, what does an opioid agonist do to stop people from using opioids? So agonists are like any short-acting opioids are agonists, full agonists, like heroin, oxycodone, hydrocodone, all the pain medications that people receive. Buprenorphine is a partial agonist, which means it does activate, it does agonize the mu opioid receptors, but it does it partially, and that's why there's a ceiling effect for respiratory depression. And then the antagonists like naltrexone, which I'm not covering in this presentation, but it just blocks the receptor and doesn't provide any activation. The agonists, they activate those receptors, and by doing that, they prevent withdrawal and they prevent craving. The big insight that Dole and Niswander, who were the developers of methadone, found was that methadone had a couple properties that allowed people, when they took it on a daily basis, not to engage in the whole addictive behavioral syndrome that we all know about, the cycle of withdrawal and all the drug seeking and disorganization of life, etc., deception. But because it was long acting, the person took it once a day, and their cravings were managed. If they were on a certain dose, they just had this kind of stable activation. They didn't have withdrawal, they didn't have craving, and that freed up their prefrontal cortex. When I'm on I always say the prefrontal cortex, like the executive system, the conscious part of the brain, the part where we're goal setting, the part where we have our sense of self, our principles, our values. When a person is engaged in short-acting opioid use, they use and then they go through this cycle all over the 24-hour period of intoxication, withdrawal, intoxication, withdrawal, intoxication, withdrawal, and that's what drives the addictive behavior that we see from the outside. Methadone creates a steady state of activation at the opioid receptors that allows a person to go out with their life. They are still physically dependent on methadone or physically dependent on buprenorphine, but it doesn't cause drug seeking. Buprenorphine is exactly the same principle because it does activate the receptors, but it does have the qualities I've talked about that are the safety profile. It also does something amazing, which is because it's a partial agonist, it only, partially activates receptors, because it has a higher affinity for the opioid receptor than all agonists, that when an agonist comes along, someone say they take their buprenorphine one day and then they use heroin later in the day, the heroin comes along to that opioid receptor and it's blocked as if the buprenorphine were like naltrexone. And so sometimes it's called an agonist-antagonist. It's an agonist at the site, but it's an antagonist to other competitive opioids. And so it does those two things. It reduces my craving, manages my withdrawal, and it prevents me from getting any reinforcement from, or not any reinforcement, but it greatly attenuates any reinforcement I might get from exogenous opioids. I say it attenuates. If you're on a high enough dose, it does fully block, but depending on what dose people are on, it might just attenuate. Let's see if I have any questions. Can Department of Transportation safety-sensitive employees take MATs? It depends on the state and the policies in the different states, and it depends on the profession. So the places that I've seen, the only profession that I've looked at in some detail, because there's information on it, is like the medical profession. And in some states, for instance, a doctor can practice on buprenorphine. In other states, I think they can't. There are certain requirements that will go along with it. And so you'd have to look with your kind of state-specific and profession-specific policy. I'm pretty sure that physicians can't generally practice when they're on methadone, but they can in some places on buprenorphine. I will say there's certainly no reason to be, it's not a black and white thing. It's not like someone on buprenorphine can't perform well in lots of professions. They do, and you would never know they were on buprenorphine. Same thing with methadone, though buprenorphine is perhaps even a little less. At a high dose, methadone can be intoxicating, but if a person's dosed well, obviously you can function and you would never know that they were on methadone. I've interacted with lots of people on methadone. I would never know if I didn't know that they were on it. So I think that just has to be taken kind of on a profession by profession, state by state, and case by case basis. How to approach prescribers at historically non-med programs who are reluctant to change even with all the data out there. I mean, I spent a lot of time doing that. I think we just keep on pushing it and engaging in conversation. I mean, I think it's important to realize that there's no ill will out there. You know, people don't hold opinions because there's some ill will. It's just that that's their perspective. And some people the views are less informed by science. That's probably due to differential exposure to science or familiarity with it. So taking a strengths-based approach and to places that are good-willed. I have to say, though, because I think there are a lot of barriers that are not only attitudinal but also financial and organizational to implementing in specialty settings or in psychosocial treatment programs, I still think we have to make a lot more use of places that are already ready to give medical care and just need to do opioid use disorder treatment. Mutual aid groups being unwelcoming to people on MAT. Generally, people that stay in mutual support programs on buprenorphine for long periods of time or methadone, they just don't report that information within meetings. They'll generally report it to their sponsor, and they'll get support from people who are open. And they then when they're in meetings otherwise, they treat the fact that they're on medication as a outside issue, not something that they need to report. And when they take that approach, generally they have good results and they can benefit from the mutual support program. But there's certainly stigma in certain places. And, you know, I mean, I just want you to, I mean, I'm sure a lot of you have experience with this, but it's important to realize that, like, I have a client who finished medical school taking 24 milligrams a day of buprenorphine. He had a horrendous addiction to IV bath salts and heroin, and now he sponsors people and he's highly engaged in AA. He's 3 years sober. He's working in a research job. He passed his boards. I mean, you can function at a very high level taking these medications, and there's no reason for people to be stigmatized for doing something that is only sensible. If I had this illness, I would take medication. But because we live in a world where not everybody will take that approach, we just need to be sensitive to not exposing ourselves to unnecessary hardship. Models of implementation in long-term residential treatment. By long-term, I wonder if you mean more than 30 days. That's what they meant in the study, the Dato study. I don't encounter a lot, very much longer than 30-day treatment anymore, so I'll just treat 30 days, or 30 to 45 days is what you're talking about. Hazelden Betty Ford has implemented just recently what they call a Core 12 program, and they have a Core 12 manual on implementing buprenorphine treatment in residential setting and outpatient care. I take issue with their guidelines because they're not evidence-based. They said they set out with the goal of making medication transitional rather than long-term maintenance. I think, great, show me the study where transitional medication use has a positive effect. There just isn't any. So we have to be agnostic about things that we might hope would be effective rather than implemented as policy, which is what they've done. So I'm not super psyched that they are putting their own abstinence-based spin on medication treatment, but they are letting people use it more. And there are other settings that are just much more, do it more by the book. Prescribe therapeutic doses, transition people to outpatient care on medication. But there are plenty of other places that say, if you come here on buprenorphine, we're going to take you off of it, and then we're going to send you back into your natural environment on no medication. And that is just a recipe for creating overdose death. And those places, I think, really should consider the medical liability in that approach. I heard in Canada they do not require people to be part of a treatment program in order to get methadone maintenance. Well, methadone treatment has been tried in the way where you just get methadone. In fact, a lot of methadone treatment is delivered without counseling. whether because patients don't do it. I know that from looking at the data. I look at all the services people get, and they get methadone treatment, and there's no counseling associated with it. So the requirements for treatment are generally minimal sometimes, like one counseling session a month after the first period or so. So I don't think it's uncommon for that to happen, but then there are plenty of places that will start a mandatory taper of methadone if someone's not showing up for counseling, whatever that requirement is, and I think that is not justified. Again, I don't want to end on the note that I hope if you take away anything else, and I think we're about out of time, so I'll just kind of end with this. The takeaway should not be that people should just receive medication for opioid use disorder, but the takeaway should be that people, when they show up for treatment that day, should get stabilizing medical care, and they should never be at threat for losing that medical treatment unless the medical treatment itself is not working, not because they failed to comply with some other requirement that has nothing to do with receiving medical treatment. That is the basic heart of the medication-first approach. It can be implemented at any part of the treatment system, and in every part that we've seen it implemented, we see that it reduces overdose and mortality risk. And if we implement it widely, and I'll end with that, our opioid use disorder epidemic will start to look like the HIV/AIDS epidemic, but we're a ways from accomplishing that. Thanks very much for your attention and for engaging. Here's my contact info. There's the 4 principles of the medication-first model and my contact information. Please feel free to reach out if you want to continue the conversation, have additional questions, et cetera. Thanks.
Thank you so much, Ned, for a wonderful webinar. We've been getting a lot of feedback. Everyone really enjoyed it. Thank you so much again for presenting. We really appreciate it. And thanks for answering as many questions as you were able to. At this time, I would like to go over our evaluation and CEU instructions. You will receive an email from us following the webinar. The email will include a link to the evaluation. Our evaluators are pleased to collect feedback from all event participants. Completion of this evaluation is critical to continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. To request a certificate of attendance or a NADAC and PCB CEU, you'll need to log into your MyIRETA profile. Once you are logged in, you will go to today's webinar and select the type of certificate you would like to download. Please note that certificates may take up to 48 hours to appear in your profile, so again, we ask for your patience. Another email will be sent around to all registrants early next week and will include a link to the recording along with a PDF version of Ned's slides. Again, we want to thank everyone for their participation today. If you have any questions, please email us at info@ireta.org. Thanks so much, everyone. Have a great day.